So, hi everyone joining via Zoom. My name's David. I'm one of the cardio fellows here at U of T and at St. Mike's. The title of my talk is Cardio-Oncology between Scylla and Charybdis. So the learning objectives of this talk are to review the foundations of cardio-oncology with a focus on anthracycline and trastuzumab-associated cardiac toxicity, discuss echocardiographic assessment of LV systolic function in chemotherapy-exposed patients, including LVEF and strain analysis, and describe practical approaches to echocardiographic surveillance of trastuzumab and anthracycline-related cardiotoxicity, including guideline recommendations, diagnostic yield, and patient-specific risk factors. So just a bit about the title of the talk, between Scylla and Charybdis. It's about a Greek mythology where sailors had to go between the narrow strait of Messina, and as the story goes, there were two sea monsters on either side. And I think this is a good analogy for cardio-oncology because on one side, you may have to stop cancer treatment due to cardiotoxicity, but on the other side, if you stop cancer treatment, then the patient could have poor outcomes from the cancer itself. So it's a difficult strait that patients, their healthcare providers, cardiologists, oncologists have to navigate each time a patient goes through cancer treatment. So many cancer chemotherapy agents can cause cardiovascular injury, and this has become a major concern among cancer survivors and during treatment as well. The term we use is cancer therapeutic-related cardiac dysfunction, or CRTD. Among the most notable cardiotoxic agents are anthracyclines, such as doxorubicin, and trastuzumab, which is a monoclonal antibody against the HER2 receptor, often seen in breast cancer. The mechanisms of injury between these two different classes are separate. Anthracyclines typically cause myocyte necrosis, which tends to be irreversible, while trastuzumab leads to myocyte dysfunction without necrosis and is often reversible if caught early. To reduce cardiotoxicity, there are two main strategies that are used in clinical practice. First is a surveillance-based strategy where you monitor patients closely with imaging and biomarkers to detect subclinical or overt cardiotoxicity, and then you intervene at that point. The second is a universal cardioprotective therapy approach where patients are proactively treated with cardioprotective drugs before injury is evident. And just to go over some of the definitions, because it's rather actually unclear in the literature about what exactly is cardiotoxicity. So if you go back to 2002 with the CREC, or CREC criteria, which came from the early trastuzumab trials, cardiotoxicity was purely defined based off of a drop in ejection fraction, either symptomatic heart failure or asymptomatic drop of at least 10% to below 55%. The definition is historically important because it was used to standardize trials early on, but it's quite limited. It doesn't detect subclinical dysfunction, which is really the key aspect nowadays. And it doesn't use newer markers like strain or biomarkers. Going on to 2014 with the ASC criteria, looking at global longitudinal strain, the addition of GLS with a drop more than 15% below baseline indicated early subclinical dysfunction, which allowed cardiologists to better identify patients who are at risk of developing drops in their ejection fraction, and promoted an approach of serial echocardiograms, but again, didn't incorporate biomarkers into the strategy. And then finally, in 2022, ESC made a more graded and comprehensive approach where they combined ejection fraction, GLS, biomarkers, troponin, and BNP into their definition and categorized people as mild, moderate, or severe toxicity, but it's quite resource intensive. And this blocks the slide. Okay. I'm just gonna turn off. Then. Perfect. Okay. And overall, what this is really showing is that we've moved from a definition of cardiotoxicity from imaging using ejection fraction alone to now more of a multimodal, multi-parameter definition to better capture patients in a subclinical state. So first, a case. A 58-year-old woman with a history of left orbital lymphoma diagnosed 30 years ago in dyslipidemia. She underwent remote surgical resection, radiation, and chemotherapy. She presented to the emergency department with syncope and exertional dyspnea. In the emerge, her ECG showed complete heart block. She had an atrial rate of 60, slow ventricular escape rhythm of 27. And getting to the echo that they did when she presented as well, I'll play the images here. You could appreciate that there's a cardiac mass with an irregular shape infiltrating the left ventricular inferior and infralateral walls in the LV and RV groove in the peristernal long axis and short axis views. You could also appreciate a moderate sized pericardial effusion with the features of tamponade. So I'll just point out here, the mass is there as well. And then now looking at the apical four-chamber view and peritoneal short-axis view as well, you could appreciate that the mass is infiltrating the intraatrial septum and posterior left atrial wall, as you could appreciate here and here. So the echo on presentation identified this infiltrating mass. It documented a normal ejection fraction, or close to normal, of 54% with a moderate pericardial effusion without evidence of tamponade. The patient ended up going for intracardiac biopsy, which I won't get into the details of. Here you can see the cath that shows the temporary pacing wire and also an incidentally identified 95% LAD stenosis. They decided not to PCI this lesion because the patient was asymptomatic and it was really identified incidentally while they were doing the biopsy. The patient went on to get a dual chamber pacemaker and also diagnosed with B-cell lymphoblastic lymphoma without any other peripheral spots identified on CT scan or bone marrow biopsy. So it was just primarily a cardiac tumor. And going through their clinical course, they ended up getting hyper-CVAD protocol chemotherapy that included anthracyclines like doxorubicin. After 2 cycles, a repeated echo was performed, and it showed a drop in their ejection fraction after exposure to 2 cycles of chemotherapy, which would have been about 2 months out. And their ejection fraction dropped from 54 to 44%. Medical therapy was started with beta blocker and statin. Due to that drop in ejection fraction, the chemotherapy was transitioned to blinatumomab, and then this did not have a favorable response. They got switched to a third-line agent, but on that third-line agent, the patient developed chest pain. They decided then to pursue PCI, but prior to that, their platelets had dropped in the context of the cancer and the treatment. They had to recover their platelet count, and eventually went for PCI, and then the patient underwent a stem cell transplant afterwards. And an important point to note is that on beta blocker and statin, their ejection fraction did recover, also rotating the chemotherapeutic agent. So they were able to recover their ejection fraction. So the reason I chose this case is it encapsulates how complicated cardio-oncology could be. You could look at, depending on your subspecialty within cardiology, you could dissect this case 10 different ways. You could look at the platelet count prior to PCI. You could look at how cancer patients are at higher risk of coronary artery disease. But in this case here, it shows how anthracycline exposure, if you're not careful, could lead to, in this case, it was asymptomatic drop in ejection fraction, which then could eventually convert over to overt heart failure. And that itself could have prevented this patient from recovering during their clinical course. So really why this is important is that we need to identify these patients early on, and looking at ejection fraction itself is actually a relatively later marker of cardiac dysfunction. So the fact that they were only caught after their ejection fraction dropped rather than due to more subclinical biomarkers or other imaging modalities is something notable. And the main challenge right now is that imaging schedules used for these agents are based off of protocols rather than evidence, and more expert opinion rather than RCTs, and more data is necessary, which we'll get into. So for trastuzumab, right now the imaging protocol is really issued by the manufacturer and the FDA when they did the original studies looking and seeing that ejection fraction drops were one of the main risks. Recommended to be assessed either through ECHA or through MUGA. And they recommend a baseline study and then every 3 months, and then every 6 months after treatment is completed. And again, these recommendations came from clinical trial protocols that identified cardiotoxicity as a key safety concern rather than actual evidence. And then for anthracyclines, a lot of, again, bodies and expert opinions recommend baseline cardiac imaging prior to treatment, but then the frequency of imaging thereafter is much less clear, and there's less consensus among major bodies in terms of that actual surveillance frequency. And in practice, monitoring is less frequent than with trastuzumab because it's less protocolized. And also, as I talk about later on, there's less incentive actually for the physicians from a financial perspective. And I'll go on to the next slide here. So in terms of this risk imaging mismatch in policy, so what I was trying to get at here is that baseline imaging is pretty widely accepted for patients starting trastuzumab or anthracyclines, but we don't really have clear risk scores to delineate how frequent or who is at higher risk in terms of developing cardiotoxicity in the literature. Most of the risk scores that have been developed are in patients with breast cancer treated with trastuzumab, so they don't necessarily apply to patients getting anthracyclines without trastuzumab or sequential anthracycline then trastuzumab therapy. And the lack of strong prospective validation in these diverse populations limits their applicability. And what I was getting at is Cancer Care Ontario actually requires a near normal LVEF for trastuzumab reimbursement. So that's actually an example of how health policy and financial incentives dictate the frequency that we actually image patients rather than evidence. And that's from the oncology side of things, not the cardiology side. And then looking ahead, this really indicates that we need to more validated and robust generalizable risk prediction models to dictate how often we actually image these patients. So these are some of the risk models that are currently available in the literature. There are a couple others, but these are the ones I focused on. So there's a model by Izaz et al. I just called it here the Izaz model that assigns points based on patient and treatment factors, giving a score of 0 to 12 and stratifies patients as low, medium, or high risk. It's derived from ICD codes looking at heart failure or cardiomyopathy. A big limitation of the score is that if you're a patient categorized as low risk, you actually still have a 16% chance of cardiotoxicity, suggesting that the model actually underestimates true risk. And it's worth noting then that if you're at 16%, you're considered low risk, that you're actually not safe. So the model practically in clinical settings can't really be used. And the reason why this might be the case is they excluded factors like baseline LVEF. Their population used was older with less anthracycline exposure, so it's less generalizable to contemporary cohorts. Looking at the SABP31 cardiac risk score, it is based off of baseline LVEF and age. The outcome was more strict, so they looked at cardiac death or heart failure with at least a 10% drop in LVEF to below 55% or a 5% drop below the lower limit of normal, plus dyspnea at rest or normal activity. But when analyzed using the more updated European Society of Cardiology definition, the model's discrimination was only modest at 0.6 to 0.69, with a discrimination factor of 0.5 being the same as flipping a coin. So again, if you're going to dictate how often you image people, you really want to have more certainty than that. And an important factor here too is that they didn't account for patients with asymptomatic declines in LVEF. So again, it underestimates subclinical cardiotoxicity. And they also didn't account for treatment interruptions, which is an important outcome for cancer patients. And then the HFA ICOS Performa score was an expert consensus tool that integrates a lot of different factors. That sounds great, like patient treatment, optimal biomarkers like troponin and BNP. It classifies patients as well into low, medium, or high risk or very high risk categories. But the score was, again, based on expert opinion rather than any data-driven process. And there are studies, including one by Basanti et al., that showed, again, a poor discrimination factor of 0.56, which 0.5 being, again, is similar to flipping a coin. So its main strength lies in it being a practical approach based off of the criteria used, but clinically, it's not a very useful tool in terms of prediction. So overall, you could see how, based off of our current evidence, it's very hard to predict who will actually go on to develop cardiotoxicity. So developing a regimen or an imaging schedule for these patients is extremely challenging, and we'll dive into a bit more detail. So this is just a screenshot from a paper that actually goes through the risk factors and how they categorize the risk for each risk factor, but I won't get into the details here. I'll elaborate a bit further later on. So talking about some of the validation issues in terms of how we choose the frequency of imaging patients, one of the biggest challenges is developing and validating the models with a lack of standard definition. So as I mentioned before, depending on the definition you use, you'll end up affecting how the models perform. So when the ESC definition is used, which incorporates ejection fraction declines in symptoms, the reported incidence is more realistic in low risk groups, like 2 to 6%. But when you use the definition from the CRC, the low risk patients kind of have a risk of cardiotoxicity ranging from 15 to 25%. So using a uniform definition for cardiotoxicity when you're applying a risk score in the literature is one major limitation. Again, also from the SABP31 risk score, excludes important outcomes like trastuzumab interruption and asymptomatic declines in LVEF, meaning it underestimates clinical burden. And then also small definitional changes, like whether you use a cutoff of 53% or 55%, could classify patients as having cardiotoxicity or not, which affects their treatment and the apparent performance of a model, but it doesn't actually fix the underlying calibration issues. And then not to belabor the point too much more, but really, again, if you're going to have a comprehensive risk score, there are emerging factors in the literature that need to be considered as well, like the patient's activity level, their ECOG score, genetic predisposition, socioeconomic factors that are increasingly recognized as being relevant. And then again, whether the score is actually generalizable to the patients you're applying it to. So the scores currently are more focused on trastuzumab cohorts rather than other chemotherapeutic regimens. And the path forward really is that we need to characterize who is truly at high risk and who is at low risk. So looking at the risk factors that are available in the literature, this table is from the European Society of Cardiology guidelines. And if you look at the high-risk patients, really from a treatment perspective or therapy-related factors, it's the anthracycline exposure with or without radiation, with or without troponin rise, with or without trastuzumab exposure, and dose-related. And then the traditional cardiovascular risk factors, but I'll talk about shortly how those are not necessarily always reliable in terms of prediction. So one of the major issues is that the patients who develop cardiotoxicity often actually look quite similar to the patients who don't. So there's one large study out of Ontario looking at population-based data in a breast cancer cohort, excuse me, without pre-existing heart failure. And the relative risk, not the absolute risk, but the relative risk of treatment-related cardiotoxicity they found was actually similar between older and younger patients, with more older patients developing cardiotoxicity as an absolute number, but their relative risk or vulnerability to developing cardiotoxicity was actually similar. Another study looking at anthracycline-induced cardiotoxicity found that among those who developed toxicity, 62% were under the age of 55. A third of the patients received low anthracycline doses, and about 94% were non-diabetic. And the rates of hypertension and smoking were similar between the two cohorts. So looking at these traditional factors that people would typically use to determine whether or not someone's at low risk or high risk aren't 100% reliable. And it's, again, important to mention that the surveillance-based strategy then to implement cardioprotection, right now there's no RCT evidence to really support that strategy. And this is especially concerning because the window of opportunity for recovery of anthracycline-induced injury is quite short. Typically, it's less than 6 months from onset of cardiotoxicity. So beyond that point, myocardial dysfunction often becomes irreversible. And the current guideline recommendation suggests cardiac imaging, right now about every 3 months or longer. So in a practical setting where patients miss appointments, there's wait times to be referred to a cardio-oncologist, there's wait times to get your echo. If you have only 6 months or less to initiate treatment, it's very easy to miss that window, which makes, again, it challenging from an imaging perspective to make sure that you're actually capturing these patients. And this was demonstrated in a study by Cardinal et al., where they looked at over 200 patients who were anthracycline exposed using echoes every 3 months. And despite fairly frequent monitoring, only 11% of patients fully recovered their ejection fraction to normal, which they defined as an ejection fraction greater than or equal to 50% once cardiotoxicity came into effect. The median onset of dysfunction was about 3.5 months after anthracycline exposure. And that's important to note that it was after chemotherapy was completed, which some patients don't get frequent imaging after treatment is actually finished. They get it while treatment's ongoing. So these patients could easily be missed. Fortunately, when cardioprotective medications are started within 1 to 2 months, there's a pretty good recovery, but about 64% did. But by 6 months, you could see that it drops off sharply. With at the 4 to 6 month mark, there's only a 7% recovery, and by 6 months, there's actually 0%. So taken away here that once LV dysfunction occurs and it's established, recovery becomes unlikely if treatment isn't initiated within the first few months. And this reactive approach of identifying drops in ejection fraction may be too late, particularly in the anthracycline cohort. So looking at the parameters recommended in the ESC, so focusing on LVEF and global longitudinal strain, they're most widely used. One of the issues that we'll talk about is with LVEF, the interstudy variability can approach upwards of 10%, which is, again, used often to define cardiotoxicity in the literature. So if a normal variation could be approaching up to 10%, depending on how you measure the ejection fraction, then you could easily end up diagnosing someone with asymptomatic cardiotoxicity, stopping their treatment and interrupting their cancer care when it's actually not true myocardial dysfunction. And then that's why more sensitive markers like global longitudinal strain are being increasingly used to identify early subclinical dysfunction and verify actual changes or drops in EF. An important caveat for GLS, though, which we'll also talk about, is that each standard deviation away from normal GLS is actually associated with a higher risk of death or adverse cardiovascular events than a similar decline in ejection fraction. So practically speaking, strain imaging is only cost effective when it's performed in a quality setting with centers of excellence that have good reproducibility. Because if you measure GLS incorrectly, again, it can have broader impacts. So looking at one study that looked at the variability in ejection fraction, actually done by Dr. Dinesh led at UHN. This study was designed to better understand how much of the change in ejection fraction reflects true myocardial dysfunction versus simple measurement variability. And the investigators looked at 88 patients with breast cancer who were undergoing chemotherapy. And to be included, patients needed to have at least 3 echocardiograms during treatment. And ultimately, 56 patients were included, and they had stable global longitudinal strain values throughout follow-up. And since GLS is the most sensitive marker for early LV dysfunction, patients with stable global longitudinal strain measurements were assumed to have preserved intrinsic myocardial function, which really means that their LVEF over time likely represents measurement error or interpretation variability rather than true cardiotoxicity. So essentially what they wanted to look at is they want to isolate and measure how much of the LVEF changes were just because of the test itself or the person interpreting it versus the actual heart changing itself. And what they found in the study was that non-contrast 3D echo showed the lowest variability in EF over time, significantly better than all other methods. And interestingly, adding contrast actually increased variability across 2D and 3D techniques. And clinically, this means that non-contrast 3D echo is the most reliable for serial EF tracking, possibly because it's more automated, using more AI and possibly better image quality and less human involvement in terms of actually manually tracing size and human involvement.
So after you remove your shirt, everything's from the waist up. Yeah. You put onto that chair, then you can take it.
Okay. Looking at inter and intra-observer variability with ejection fraction, 2 observers were used in the study to read the same studies twice at different time points in order to identify the difference between how the same person would interpret the study over time and also how one person would interpret a study compared to someone else. And the lowest variability was again seen in the non-contrast 3D echo, showing an intra-observer variability of 1.7%. So looking at the table here from the study, the intra, so within the same observer, there's about only a 1.7% change over time, while inter study variability was 2.7%, while compared to other modalities, these range between about 3 to 4% in terms of intra-observer, and in terms of inter-observer variability, it ranged about 4 to 5%. And the authors did a statistical technique where they called it the minimal detectable change, where they took the smallest difference in ejection fraction that could be considered statistically real rather than just measurement noise or error. And they did this by, they used a 95% confidence interval derived from 2 times the standard error of the mean to estimate the threshold, again, where EF could be, the change in EF could be considered actually real. So in practical terms, this means that if you repeat an echo on the same patient, even under stable conditions, the EF could vary up to 5 to 6% using non-contrast 3D and up to 10 to 13% using 2D methods, purely because of physiological loading, acquisition differences, and reader variability. So any change in EF smaller than those percentages, in theory, could represent not real cardiac dysfunction and just due to extraneous factors, which again has big impacts on actually diagnosing cardiotoxicity, because again, a drop of 10% would trigger stopping someone's chemotherapy, putting them on cardioprotective medications, and so forth. So some key limitations here, again, as I talked about before, a 10% variability has direct impacts in terms of diagnosing patients. And then when we look at LVEF as a measure itself, by definition, it's the fraction of end diastolic volume that's ejected at the end of each beat with, EDV minus ESV divided by EDV. So if the EF tells us about volume change and it's not intrinsic contractile performance, a ventricle could have impaired myocyte function, but as long as the volume shift normally, the EF could look okay and vice versa. Second, geometry matters. So with an ejection fraction measurement, it assumes that the LV is roughly ipsiloid. So when that geometry changes, the link between muscle shortening and cavity volume becomes distorted. So if you take a hypertrophic ventricle with a small cavity and thick walls, even with a reduced contractility, the volume change can seem large relative to the tiny chamber in the heart. So it could overestimate ejection fraction. And if you have a dilated ventricle, the opposite is true, where you have a big cavity ejecting a large absolute volume of blood. But since the denominator, the EDV, is large, the fraction of ejected blood could appear small, and here it could underestimate your ejection fraction. And to add to that, the effects of loading conditions and image quality, you could see how EF could be highly variable depending on the geometry of the ventricle and the loading conditions. And that's why, again, using GLS, 3D echo, and CMR is becoming increasingly popular. So just to briefly explain strain analysis. So strain tells us about how much the myocardium shortens, thickens, or twists as it contracts. The heart muscle itself isn't uniform. It's made up of fibers arranged in three main directions: longitudinally, the heart muscle, longitudinally running from the base to the apex along the endocardium, circumferentially wrapping around the midwall, and radially moving inward and outward to thicken the wall during systole. And with echocardiography, you could track how much each of these fiber layers deform during a cardiac cycle with a technique called speckle tracking. And the most commonly measured value is global longitudinal strain, so measuring it longitudinally. This measures how much the heart shortens from base to apex during contraction. And it's expressed as a negative percentage because the heart is shortening, and that's how it's captured from a negative perspective. But you can look at absolute numbers in terms of the number declining. So a normal GLS globally is around negative 18% to 22%. And the more negative the value, the better the heart is contracting. And what's powerful about strain analysis is that it can detect these subtle myocardial dysfunction before it drops in EF. So here on the left, so putting your attention here, you can see a patient's baseline bullseye plot before starting chemotherapy with a global longitudinal strain of negative 28.1% and the injection fraction measured at 61%. 6 months into getting chemo with anthracyclines, the GLS has declined to negative 17%. And I know with saying a decline when the negative number is getting smaller can be confusing, but just look at it from an absolute perspective. The ejection fraction is still fairly preserved at 55%. And if the patient's asymptomatic, this is something that just could be easily missed and not cared about. With the drop itself only being 6% from an LVEF perspective, but the absolute drop in GLS being 3% actually represents an absolute reduction of about 15%, which is a significant drop that would be identified by the cardiologist. And then looking at by 12 months, the GLS has now fallen to negative 16.1%, which is an absolute drop of about 4% from baseline. And now the EF has dropped below 49%, which would meet cardiotoxicity guidelines. But you can see how here, if you were to look at GLS, you'd be able to identify the subclinical dysfunction early on and intervene before the ejection fraction actually dropped or the patient developed symptoms. So going into another case here, this one focuses more on trastuzumab. 37-year-old woman with early stage ER-positive, HER2-positive infiltrating ductal carcinoma of the right breast. She received 6 cycles of chemotherapy, including trastuzumab, has a double mastectomy and maintenance trastuzumab as well. This is her baseline echo. So normal cardiac function. And then after trastuzumab exposure, we could appreciate that after 3 months of trastuzumab exposure, her ejection fraction had dropped from normal of 59 down to 47. And they'd measured the GLS as well, which dropped from negative 23% to negative 12%. And this was asymptomatic without any heart failure symptoms, which represented subclinical dysfunction. She was put on beta blocker and ACE inhibitor. Trastuzumab was held, and they repeated serial echoes. And after initiating treatment and withholding trastuzumab, they were able to actually normalize the ejection fraction, reinitiate trastuzumab, and subsequent echoes on trastuzumab were actually normal. So this pattern is typical for trastuzumab-related cardiotoxicity, which is often reversible. And with anti-remodeling agents, cardiac function often normalizes and patients could continue on trastuzumab after being stabilized. So as we talked about before, the current recommendations for LVEF imaging for trastuzumab are based on trial and expert opinion rather than evidence. And actually, when I was a medical student, I got to participate in a study here doing a chart review at UHN when we looked at 448 patients who underwent 1,700 cardiac imaging studies after trastuzumab exposure. We found the incidence of cardiac toxicity was actually relatively high at 21%, but this was likely due to the fact that most of these patients had prior anthracycline exposure, putting them at higher risk of cardiotoxicity. Looking at routine tests, so tests done as per schedule, like at baseline and then every 3 months afterwards, the yield of those routine tests was actually only 2.8%. But if you looked at on a per patient basis, that actually affect the test changed care in about 1 in 10 patients. So it was important on a per patient basis, but the number of routine tests rarely actually changed care. And then if you were looking at tests that were clinically prompted, so if patients had symptoms at previously abnormal imaging tests or concerns from the clinician, they were 10 times more likely to detect a drop in ejection fraction. And this was before the time of GLS. So prompted tests were much more likely to change care. And recognition of cardiac dysfunction through tests allowed for temporary trastuzumab interruption and then cardioprotective medical therapy being started, with the takeaway point here being that routine cardiac imaging actually rarely changes management. And more of a selective and risk-based approach is needed. So here are 2 tables from the study that I just want to highlight. These 2 figures show that the timing and sequence of routine cardiac tests affected their usefulness. So the bar graph on the left is looking at the timing of tests, and you can see that routine studies done between the months of the 3-month mark and the 9-month mark after starting trastuzumab were most likely to lead to changes in care. And then after that, the yield dropped off and no new management changes were triggered by routine tests after the 16th month mark. And then the figure to the right shows what happens as patients have more and more routine tests that don't show change or don't show any abnormality. The yield falls steadily with each additional negative test. And once the patient has 3 or more routine tests that didn't change care, the chance of a new actionable finding be identified on echo is very low. So together, these figures suggest that we could, again, tailor the frequency of when we make testing more focused in the intensity of testing in terms of their timing, and then when we could back off on testing potentially. And again, this reinforces that the one-size-fits-all approach to the current standard of how we're imaging cancer patients isn't really effective or cost-effective. And the likelihood of finding something actionable, again, even though the prior studies we talked about, it's not a perfect science where just because someone has more anthracycline exposure or more cardiovascular risk factors, they're necessarily going to develop toxicity. Statistically speaking, they are at higher risk. So taking these factors into account. And then for low-risk anthracycline naive patients, again, it's not a perfect science because there's exceptions seen in other studies, but maybe less frequent imaging, particularly outside of high-risk periods when they're being exposed to cancer treatment, they may be able to be imaged less frequently to decrease imaging burden. And outside of Canada, if you look at the UK or other trial protocols, they actually image patients less frequently. So there are different models to go off of. So this then leads into a study that I believe St. Mike's is actually a part of. It's the JUSTIFY study. So the judicious surveillance of trastuzumab-induced cardiotoxicity in the first year. It's a randomized controlled trial. And the goal here is that they're trying to randomize 300 women with pre-existing heart disease. And this is currently ongoing. The exclusion criteria of women with pre-existing cardiovascular disease or cumulative anthracycline exposure of greater than 250 milligrams per meter squared before starting HER2 treatment. And the intervention is a risk-based imaging strategy. So for low-risk women who have no risk factors for cardiotoxicity, they're going to get 2 fewer tests per year. And for intermediate risk patients who have a risk factor for cardiotoxicity, they're going to get 1 fewer imaging test compared to the control group, which is the standard of care right now. And they're looking at outcomes trying to be more comprehensive than what's currently available in the literature. So they're looking for overt heart failure. They're looking for premature discontinuation of HER2 therapy. They're looking for asymptomatic cardiotoxicity. They're looking for patient-reported outcomes and the time to complete treatment. And this approach allows researchers to consider not just heart safety, but also treatment completion, patient mental health, and imaging burden. And if successful, the study could safely reduce the unnecessary number of tests being performed on cancer patients and improve the patient experience and lower healthcare costs, and actually provide some evidence in terms of how frequently we need to image patients. So in terms of future directions, and just to kind of summarize, Cardiotoxicity is common, but often partially reversible if detected early. Routine surveillance itself has a modest per test yield, but meaningful per patient impact. A targeted risk-adapted monitoring approach is needed, and further research is really needed to, again, better identify who's actually at risk, what risk factors do we need to pay attention to, and then what modality should we be using to judge when to stop treatment or interrupt cancer treatment for patients. So really a big highlight of the talk here is to really show how much of our current practice isn't actually based off of evidence, and there's actually so much uncertainty in what we do, and it's largely actually based off of expert opinion or trial data. But there's a lot of new evidence emerging in terms of how we're going to organize and time testing. So I want to make sure to highlight the references as well, and happy to take any questions.
So thank you, David, for summarizing this field, and want to hear more about what will you propose for treatment later on. But just to give a bit of a perspective to all this in history. So up until 10 years before this, patient who received chemotherapy for breast cancer, they don't get echo. What do they get? Well, that's really hard to access for cardiac MRI. Mugger, yeah. So like many of my patients, including my family members, actually who has undergone treatment, actually had to go through muggers. And like that was considered to be a magic numbers, and most of the oncologists at the time actually really stuck to that. And it took us more than 10 years to actually convince our oncology colleague that echo is a viable solution in terms of ejection fraction. And really what sealed the deal at the very end for the field of echo in the, into cardio-oncology is the development of global longitudinal strain. So that was actually historically. Now you actually hardly see anyone actually getting mugger unless they're very technically difficult. Sometimes, you know, with mastectomy, it becomes very, very difficult. So occasionally, even with echo contrast, we have a hard time actually getting a reliable EF. Very rarely, but that also happens. So they do get back to mugger. But it has made as a long journey for echocardiographer to be part of this. So that's actually historically the trend. And one of our colleagues, Dr. Dinesh at UHN, has really pioneered this field in when he was in Cleveland Clinic, and that was the paper that was published and then brought into Canada. So we have a very strong research base at UHN, and we are part of the big family as well. So I want to talk about treatment and also how often we should follow up. And also one of the biggest challenge that we have as clinicians is figuring out when to actually stop the treatment after they stop the chemotherapy, if they recover the EF. So that's actually often puzzling for us. And do you have any guidelines that you come across?
Yeah, there's evidence on that for the for the purposes of my talk, because I understand there's an upcoming talk on the treatment. So this is kind of a prelude to another talk coming up in November, I think more focused on the treatment of cardiotoxicity. But in terms of the treatments now, like there's a lot of more literature on the use of ACE inhibitors, beta blockers, SGLT2 inhibitors. There's also now the use of statins being used for their pleiotropic effects in cardiotoxicity. And I think the decision to stop treatment is relatively nuanced and challenging for patients. But ultimately, if you meet the criteria for cardiotoxicity, my understanding is that they'll often temporarily pause, at the very least, initiate treatment, do serial follow-up with imaging, look for recovery. And if recovery is not identified, they may rotate chemotherapy protocols. But it's definitely a challenge, because the longer time, again, you get off of cancer treatment, the potentially worse outcomes for the cancer patients. But particularly if identified early, as noted in some of the studies here, I think the anthracycline table is quite nice, or the chart. If you identify these patients early on and get them on appropriate cardiotoxic treatment, most of these patients do recover, and then they're able to be retrialed. With anthracyclines, less so, but with trastuzumab, for example, they could be put back on treatment and then continue on their cancer therapy journey.
Yeah. And once they recover the ejection fraction, do you continue with beta blocker?
So that's a great
treatment forever? Or
yeah. So there's actually,
what point can you withdraw?
There's currently an RCT going on that I was reading about, and the name's escaping me right now. It's also it involves researchers from Toronto as well, the same group, where they're looking to see the safety of withdrawing care, because it's often a question that patients have. Be similar to how our patients, we keep them on heart failure therapy after they recover the EF. Is it the same phenomenon with cancer or cancer therapeutic associated cardiotoxicity? Can you stop after the treatment's stopped and the EF has recovered? And there's a current RCT going on to answer that question. I'll have to get back to you on the name of it. I have to look it up. It's currently going on.
Yeah, it's a clinical echo point. So
Yeah.
often when we have clinicians that we struggle with that, because after they finish their 18 cycles, we got them through of trastuzumab, and then like, what do you do that? What do you do after that?
Yeah.
And some patients are on it, some patients do not really want to be on it, so just keep following. So anyway, it is a clinical echo point, and we do need an RCT on that one. So any questions from the audience? So question from the audience is, how old is this study?
Let me cheat here.
2016.
That's the one I cited the table from, but let me get the actual study for you. I have it in my, yeah. Let me get it for you. I wonder if that holds true when you add RNA, when you add SGLT2s. Yeah, back in, it's back from the mid-2010s. Yeah, they may not have SGLT2s. That's true. That's true. Yeah, I mean, in terms of the exact treatments they put the patients on, let me see if I have it here. 1 second here. I think it was ACE and beta blocker, but I'd have to double check. That is a good point that the SGLT2s at the time were not as prominent. And also, I think statin therapy was still being identified as an option. So you're right. Now we have more options in terms of putting patients on. So recovery may be higher now if the study was repeated. I think that's a good point.
As familiar with the literature, but a lot of the therapies that we use for heart failure with reduced ejection fraction, the benefits are clinical.
Yes,
so
true.
Not necessarily benefits of increased LVEF.
Right.
So I guess you have to look at, for example, I don't know if there's any study that shows that they result in improved heart failure.
So following Dr. Leon's comment, there's a couple of questions from our audience online. So here's one of them. You mentioned earlier that oncology patients are more predisposed to CAD, and why?
Yeah. So I didn't focus on that element because I want to focus more on the echo aspect, but there's a broad literature on how these patients are likely due to the underlying factors that contribute to the cancer itself, or the cancer, either the risk factors for cancer or the cancer itself actually increases inflammation and actually has a similar pathogenesis or exacerbates the development of atherosclerosis. So things like having diabetes, things like being obese, contribute both to cancer, but also contribute to atherosclerosis. So whether it's the factors contributing to the cancer itself also then contribute to the development of atherosclerosis versus the cancer itself increasing inflammation, which is also contributory to the development of atherosclerosis as well. They're both intertwined. So many patients with cancer also end up having a CAD burden. And, the first case I talked about, if this was a different talk on PCI and atherosclerosis, you could talk about how managing CAD, particularly in patients with like low platelet counts, increased risk of bleeding, it become very nuanced and complicated. And hence, for example, in this case, the patient had a 95% stenosis, but was chosen not to intervene until it was absolutely necessary because, again, the risks of bleeding and the complications and having to need to go for things like stem cell transplants.
Yeah, it shows that the online questions are very good researcher. You guys are all asking great questions. So the other one that came through, it's any evidence for SGLT2 inhibitors improving GLS and outcomes in this particular population?
Not that I'm aware of, no.
Yeah. Anyway, this is another clinical echo point.
Yeah, probably so. They're probably going to show it.
Yeah. That just requires another clinical trial. So it just shows that, this is a field is fairly nascent as we speak. I mean, when you think about this, 10 years ago, like going back to 10 years ago, none of this, what we just talked about, actually exists. I mean, it was still struggling. Trastuzumab just came on the market about like 12 or 15 years ago. And then, this 20-30% of people having like, reversible cardiotoxicity came out, and that was also a big transition between MUGR and ECHO and GLS at the time historically. So lots of questions to be answered, and SGLT2 only came on within the last 8 to 10 years into this field of heart failure. So the other last question here so far is, you mentioned that one of these two agents cause irreversible changes. If this is the case, how does the EF actually recover?
Yeah, so I think I didn't get into the pathophysiology, but from my understanding, it's that if you're able to intervene early enough in the toxicity for anthracyclines, from my understanding, you're able to intervene before the necrosis is fully set in. So it becomes, once the necrosis is fully set in, that is then irreversible, or the damage is irreversible. But if you're able to intervene while there's still more subclinical dysfunction, or just the toxic effect of the chemotherapy, that process is intervenable. But my understanding is once the toxicity is fully in place, you have necrosis, and that change is irreversible. So that's the difference between anthracyclines and trastuzumab, where trastuzumab isn't going to necessarily cause that that necrosis, but in anthracyclines it can. But if you intervene early on, you stop the anthracyclines, you give medications, that process could be intervened on if you identify it early on.
Yeah. So so most of the irreversible ones that we have seen is actually on the anthracycline side, especially when the dose is high, in the 400 plus range. We see this in other chemotherapeutic or cancers of situations where anthracycline is also used as well, in addition to breast cancer. This is another one, a follow-up question or follow-up comments. This is just an anecdote, seen NT-proBNP drop with SGLT2 like other heart failure patients, but not sure if this correlates with any survival benefits in this population. Again, this would be a great research question. But can you comment on the use of NT-proBNP and troponin in the diagnosis of cardiomyopathy or cardio-oncology situation?
Yeah, so looking over at the definitions used, so the more recent definitions, like from the European Society of Cardiology, now do incorporate troponin elevation and BNP into the risk stratification in terms of diagnosing the severity of cardiotoxicity, so whether it's mild, moderate, or severe. So in the mild definition, they actually do consider an elevated troponin or BNP to be considered to have mild cardiotoxicity, with or without actual echo changes. So the use of biomarkers is now being used as a way to, again, identify subclinical dysfunction. From my understanding, it's not used to necessarily abort treatment yet, but it's a way to identify early on. And for example, if you were to detect a high troponin or a high BNP, that should then definitely trigger you to do an imaging test. And then if you meet criteria for dysfunction, then, treatment decisions and whether or not to continue cancer therapeutics or start cardioprotective medications would be indicated.
Great. We have 3 minutes left. Any other questions from the audience?
Question: do you know, or do you know if there's any data about, like, is the ventricular dysfunction after starting these agents, does it tend to affect both ventricles? Is it more of an LV problem?
Yeah. Do you want to just repeat the question? Is a difference between LV and LV involvement?
Yeah. So
in cardio-oncology.
So the question was whether chemotherapeutic agents affect the RV and LV equally. The honest answer is I don't actually know the details of that. Most of the literature I read reported on and measured the LV function. It's possible that maybe in supplemental data or other studies, they do comment on the RV function, but a lot of the definitions to diagnose cardiotoxicity and then in the trials, and then also currently how they're assessing responses to treatment, they report the LV function. So I don't know if there's as much robust evidence on RV function. So it's difficult for me to comment on based off of what I read. But right now, really how things are categorized is based off of the LV.
Great research question.
Yeah.
Again, research project could be done. And you have a slide actually commenting on the RV. If it's affected, then it's more likely, especially with pulmonary hypertension. So I'm actually paying attention.
Yeah, you're right. Actually, I do.
And
should pay
like
more
then,
attention.
it's actually worse prognosis. But that is made. Like, it's we're very LV focused at this point in for this particular disease category.
Yeah,
I think there's going to be a lot of work that needs to be done in this category, like in the area of LV, which is often considered to be the ignored neighbor.
So there are diagnostic criteria for cardiotoxicity with RV function. It's just I think most of the studies focus on the LV, but you can diagnose it with RV dysfunction.
Yeah, all our decisions algorithm has always been focused on the LV, ejection fraction, GLS, LV size, etc. So, but anyway, this is a part to come.
Yeah.
So more to develop in this field. Okay, so with that in mind, we are about 1 minute away. Thank you everyone for joining today, and I hope you enjoy the presentation. And please remember to do your survey so that you can get your CME for those one who need it. And also, don't forget, we also have a St. Michael's Cardiology virtual rounds channel, so you can sign on and check it out. And for our echo rounds, we are actually inching towards 7,000 subscribers. We're only like 10 or 15 away, so encourage your family members, friends, and colleagues to join. Thank you. See you next week.